Looking for what's next in NHS imaging and radiology? Then don't miss RadVision South in partnership with AXREM, taking place in London on the 8th of July. This is where the UK's imaging community comes together, from NHS leaders to industry experts to tackle the real challenges: workforce pressure, reporting backlogs, AI in practice, and the future of diagnostic imaging. Expect big ideas, practical solutions, and conversations that actually matter. And of course, plenty of time to connect with peers across the sector. Places are limited, so book now at conventus.co.uk. RadVision South. Be part of the conversation shaping the future of imaging.
Welcome to AXREM Insights, the podcast where we explore the technologies, people and partnerships shaping the future of diagnostic imaging and healthcare innovation. This is our conditions series, and this month our focus is on cardiovascular disease. I'm Sally Edgington, and I'm here with my guest host, Giulia Ginami, AXREM Future Leader Representative and Collaboration Manager at Siemens Healthineers. Today we have the pleasure to be speaking to Dr Sohaib Nazir, Clinical Senior Lecturer and Honorary Consultant Cardiologist at King's College London and the Royal Brompton Hospital. So welcome, Dr Nazir, and thank you for being on our show today. Let's start by handing over to you to tell us a bit more about yourself and your career so far.
Oh, wonderful. So thank you, Sally and Giulia, for the very kind invitation. It's a real pleasure to be here this sunny afternoon in London. So I'm a academic cardiologist. So I practice as a clinical cardiologist at Royal Brompton Hospital in cardio-oncology and imaging. And I've also got lucky enough to have a academic post as well at King's College London, where I spend half my week also doing academic research and innovation. My interests are very much in cardiovascular imaging, all types of cardiovascular imaging, and also trying to look at new pathways and imaging technologies to help improve the lives of my patients. And my specific area of interest is looking after cancer patients with heart disease.
Brilliant, thank you. And what kind of got you into this career? Was it something that you always wanted to do from a young age?
Great question. So very much serendipity. Looking back about 10, 15 years ago, I never thought I'd be where I am at the moment in a fantastic institution supported by excellent colleagues and also in this field. I changed direction a few times in my junior training as a junior doctor, but one thing led to another, and then eventually I found the field of cardiology. And then somehow I managed to do a PhD in cardiovascular imaging here, actually when Giulia was a PhD student as well at the School of Biomedical Engineering and Imaging Science at King's College London. And that's when I fell into love with imaging. And then the career just helped to develop after that.
Fantastic. Thank you. And Giulia, do you just want to tell us a little bit about your career? Because it sounds like you've kind of got a similar type background.
I'm originally from Italy, and I graduated there in engineering. After that, I spent some time in research. I have a PhD and a postdoctoral background in cardiovascular MRI. And after a few years in research, I joined Siemens Healthineers, first in marketing for magnetic resonance, where I was responsible for some products and their market introduction. And then slightly more than a couple of years ago, I joined our collaboration department, which means I'm responsible for partnerships with academic realities, in particular here in London with the King's Health Partners. And I design and drive projects around innovation and clinical validation of new technologies.
Wow, thank you. I have to say, I'm glad I'm just the host today because I feel very underqualified. So today we're turning our attention to one of the most significant health challenges of our time, cardiovascular disease. It remains the leading cause of death globally, but it's also an area where rapid advances in imaging, AI and medical device innovations are transforming how we detect, diagnose and manage heart conditions. In this episode, we'll be diving into the realities clinicians face on the ground, the breakthroughs emerging from industry, and the collaborative efforts driving early diagnosis, more personalised care, and better outcomes for patients. From cutting-edge CT and MRI technologies to the evolving role of interventional imaging and digital tools, we'll explore how our sector is helping to reshape cardiovascular care. Whether you're a radiographer, a clinical leader, a policymaker, maker or part of the wider medical technology community, this conversation is for you. It's about understanding the challenges, celebrating the progress, and shining a light on the innovations that are saving lives every day. So we'll deep dive straight into the questions. Cardiovascular disease is often described as a silent threat. From your perspective, where are the biggest opportunities to improve early detection, and how can imaging play a more central role in reshaping patient pathways?
Thanks, Sally. That's an excellent question. And I think one of the really important aspects to think about is what can we do for our patients now and what can we do for our patients in the future. So there's already really well-established therapies out there for patients with established cardiovascular disease. As an example, let's take the disease process of heart failure. Once it's happened, there's actually quite good therapies now available. But actually, I think one of the major challenges for us and the major directions of in the future as a silent threat is about trying to prevent these problems from happening in the first place. This is where imaging is, as a non-invasive tool, is really, really well suited to try and detect these kind of changes early. But the key thing is we need to use the right tools which are clinically meaningful and then things that we can actually action upon to prevent deterioration in the future.
Thank you. And Giulia, do you have anything to add there?
Yes, I think I'm perfectly aligned with what Sohaib has described, and I think, in general, technology plays a key role, and it's important to also, look at technology not just from the technical footprint, but also the role that it has throughout the entire pathway. So, to make individual technologies better, being it a specific imaging device or a specific interventional device, but also the role that it has in streamlining the patient pathway throughout. We are seeing rapid advances in CT, in MRI, in ultrasound, and in various technology also when it comes to AI-driven component and analysis of those. And from your perspective as a comprehensive clinicians when it comes to the cardiovascular space, which innovations do you believe are genuinely moving the needle in cardiovascular care, and what are the barriers also that you see still exist to the wider adoption of those?
Great question, Giulia. And I think, as a multimodal imager, I really, really appreciate all aspects of all the different kind of technologies you just described. There's actually lots of out there that I think are really good, but the ones that I think are really powerful in making a difference and adding incremental benefit on what we're already doing, perhaps a few of them. So if we look at CT, coronary angiography, plaque-based quantification is really going to be is changing the paradigm of how we think about our patients and how we treat them. MRI is fantastic, and cardiac MRI is multi-parametric, as you know, so you can essentially take the same pitch of the heart several times using different techniques and get different information, which is really, really a fantastic asset to cardiac MRI. And actually, the processes and the technology and the techniques behind there, as Giulia's alluded to, have rapidly evolved. So we're taking images faster, we're processing them faster, which means there's less time needed to try and understand what those images mean. And if we just take the last example of ultrasound, so ultrasound is very much the workhorse of cardiovascular imaging, so looking at transthoracic echocardiography. And there's been huge strides made in the field of echocardiography to do AI-enabled assessment of the heart function, for instance, with ejection fraction. And these tools are now readily available, and I think they're really, really developing further and will continue to do so over the next few years. I think that said, that these tools are out there, but I think one of the major challenges is about the deployment and the acceptability of and getting these tools made available readily for clinical use. There's always a long lag time, and if you look at all the great work that Giulia did in the past in the research studies, once those studies are done, there is some time before that kind of technology is taken up by clinicians and deployed readily. But that's why you need industry, and that kind of partnership with the academic, industry, and healthcare interface is the one that really will take and churn this way forward.
Yeah, and I think one of the things I hear from our members is it can be quite frustrating because AI is an amazing tool, but obviously getting it upscaled and deployed is you can get lots of trials into trusts, but actually then getting them to spend the money, even if they see the value, seems to be one of the blockers. Do you experience that yourself or hear that from any of your colleagues?
Yeah, I think that's a really important point. The actual deployment process and the acceptability and usability at the point of the interface with the healthcare trusts is a challenge. But
Mm.
that's where I think we need to, as a healthcare system, be a bit more adaptable, flexible, and dynamic to be able to, take on those kind of new tools, the things you mentioned already, the AI tools, as an example, and embrace them so that we can start using them before those techniques expire and the next thing comes out. Because actually, if these tools are already there, we should be using them.
I totally agree. And I think I see it frustratingly because, some of our members have tools that are being used in all other areas of the world,
Yes.
yet UK patients are not, seeing the benefit of them. So for me, it's very frustrating, representing industry and suppliers of all of those tools. So, yeah, I think we definitely need to upscale at more rapid pace within the UK once we know that something works and that it is making a difference to a patient's life.
Agree completely with you, Sally, there.
Great, thank you. So, clinicians are under huge pressure across the system. What does the day-to-day reality look like for teams diagnosing and managing cardiovascular disease, and how can industry better support you and your colleagues?
Thanks, Sally. So just to maybe put that in context, there's a lot of behind the scenes work that goes into seeing a patient, managing them and diagnosing them appropriately and starting them the right therapies. And if we just take a few maybe snippets, and I won't map out the whole pathway, but you might get a letter in from another clinician, from another doctor, from another hospital, or from a GP that then gets processed, that then gets triaged, some tests are done, and then those tests are done and interpreted in perhaps a multidisciplinary team meeting. The patient's then seen and discussed, and then a letter is generated. All these points, that pathway, require time and administration. So they're all the behind the scenes work, which are really, really important. But actually, if you just map out maybe 6 or 7 of those processes, actually the amount of time you actually spent with the patients is actually not that long. All that time it's take to, like, let's retrieve that information, get that test done. There's quite a lot of administrative work behind the scenes that isn't always captured and probably appreciated by everyone in healthcare. So I think one of the biggest things I think industry could think about doing is trying to enhance and streamline those administrative processes. That means that we can spend some more time with patients, because these tools and technologies you mentioned, Sally, and we discussed so far, are already out there in terms of the imaging based ones. So actually, if we're able to embed those tools already in that pathway, we might be able to improve the way our patient pathways and protocols, and hopefully improve the patient experience as well. I think to do that though, we talk about simplifying process, but also we need, as clinicians, we need the right kind of tools that are user friendly and can be deployed readily at scale on systems that we use. So if it means that you need, let's say company X comes up with a fantastic tool and that can solve lots of things, but you need a high processing, high spec computer that requires a high-end graphics processing unit, that costs 10 or 15,000 pounds, and a workstation at different place. That's not going to readily work. But actually, there's actually lots of innovative solutions out there, but like using cloud-based computing that might be able to overcome those challenges. So I think, if we have those kind of user-friendly interfaces that can be embedded at point of care, those are the things that are going to be helpful and solve problems for doctors, and also let us spend more time with our patients.
Yeah, and I think you all become clinicians because you want to help patients, and ultimately you want to have time to spend with patients. And I always say that some of the innovations and technologies that AXREM members provide create those efficiencies to enable you to spend more time. So I think we just need, I bet you all of the solutions are out there. It's just a case of finding them and putting them all into one pathway. And I think that's the challenge. And I think the other challenge is about how they all integrate with one another, because there's so many different innovations and products out there. So sometimes that can be a blocker, is how they integrate. And I know that when we sometimes speak to members, an IT department within a hospital think about computers, but actually most med tech products are connected in some way to the IT infrastructure. But so there's not always that great understanding of how they should all integrate internally within a trust. And I'm sure you've probably come across that at some point.
Yeah, I mean, I've had lots of challenges the past years, but even deploying, simple softwares potentially that might be quite helpful, because there's a number of barriers that, number of processes you need to get through to get into the very secure NHS system and deploying on to healthcare records or those kind of computers. Um, but I think what you just said really summed it up. There is a lot of stuff out there already, a lot of tools, and actually they're all as in the small piece of a jigsaw. What we need to do is just put that jigsaw together. And then we need to continuously update and refine it rather than wait for the system to break down. And they say, oh, well, now this is a new problem we've got or a new diagnosis. Actually, we need to be more disruptive and innovative and put those jigsaws together dynamically and be able to move them as time goes on. So it needs a bit of a rethink about how we do things, but the tools are out there. We need to get on using them.
Yeah, I agree. And I use this term a lot. We talk about one NHS, but actually there's lots of different trusts that are all doing their own thing. Do you think that that is a good or bad thing? Because I wonder whether that is a blocker to some of this innovation and technology that could help clinicians.
Yeah, I mean, I'm just reflecting when I was a medical student about 20 years ago at Imperial, and I heard about having a one national IT system dream. And that was the policy about 20 years ago, and Lord Darzi was health minister. It was a great idea, and they was going to have this NHS backbone and spine and have a one system. 20 years later hasn't really happened. And as you say, people are not necessarily working in silos, but they have partnerships. So there's large organizations. So we're part of King's Health Partners, Guys and St Thomas's, Royal Brompton, and Harefield Hospital, which is fantastic. We've got very, very large infrastructure, but actually we're not always connected to the rest of the UK. So we've got a fantastic operating system, what we're using at the moment, but actually it's about having those integration and having a bit more centralized way of managing these things that it can be rapidly deployed. And if we're all using similar systems, we can all communicate far better.
I think that would be the absolute ideal situation. I think the reality is the NHS is I mean, obviously the biggest organisation in the UK. So I think deploying one system for everyone would be a huge challenge. But actually, it's one that we should be looking at. And I think one of the other things, and I don't know whether it's the same in cardiovascular care, but one of the things I see in general diagnostic imaging is there isn't currently one register that keeps all of the images. So for instance, my son was taken poorly in Cornwall and had a CT scan, and when he came back home to Northamptonshire and was taken poorly a couple of weeks later, he had to have another CT scan. And to me that just seems crazy that that information is not shared across trusts, because with a workforce shortage and obviously with the economic situation and funding within the NHS, that would be a massive cost saving and a time saving, and obviously help with the workforce. Do you see that in cardiovascular area as well?
So Sally, you made an excellent example. Then I'm sorry to hear that your son had to have another CT scan, because that's not what should be happening. But that's a very good example where we can avoid duplication of resources and duplication of testing. So in fact, a lot of my time in my week, my admin time when I'm seeing or processing these patients, I spend a lot of time actually requesting images from other hospitals, because we're not on the one system or that one registry where you can be able to access and pull data. Because if you have all that access ready, you don't have to, you don't have to waste time importing that data. And then you could use that information to guide guide management of those patients going forwards as well. So I think and I think the way that needs to be done is actually, even if we're operating on separate systems, we just need to have easy accessibility to others' electronic healthcare records and DICOM data sets and packs and whatever we're using, so that we've got all that kind of information ready to hand, so we can improve the way we treating our patients going forwards.
Yes, I mean, it's a very fascinating conversation. And one point that came to mind while you were talking, Sohaib, I was thinking, I mean, someone in your position, you have this very unique and in a way very interesting and privileged setup where you are fully embedded in the clinics through your Brampton activities, as well as in the research, right? And I would imagine that you see a gap between what's actually available to patients these days and what we have developed as human beings with our thoughts and with our implementations, and what would be possible for them to have. My question is, how, from your perception when it comes to cardiovascular care, how big do you think this gap is? And also from, let's say, a personal perspective, is it frustrating for you to see that, maybe there is a certain technology available to patients while meanwhile something much more detailed and much more suitable perhaps has been developed, and that's not something that you can offer to them at this point in time?
Yeah, it's a great question, Julian. I think, as you say, I feel really privileged because I'm at the academic institution where it's at the cutting edge of these new technologies that Giulia and the team are developing at Siemens Healthineers and other industry members. And then then I see what we're doing now on the patient side. So I think there is clearly a gap, but that's where I think, we need to have those kind of disruptive technologies where we're able to try and use those technologies at an earlier pace and embed them in the healthcare system. Sometimes it has felt frustrating. I think, there's clearly an answer to this, but it just sometimes just needs a sensible approach and say, look, what have we got? What are we trying to do? Let's just put these tools together and put that jigsaw together, and then the cogs will just start moving, and then you'll have a very, very rapid way of getting all these processes done and improving, and then moving the patients forward, getting more patients seen, more diagnosis done, and the early treatment initiated for the patients, and that's going to be the things that are going to improve our healthcare system.
And I mean, on the basis of these, and in line with what we have discussed, that if you could change one thing about how we approach cardiovascular disease in the next 5 years, whether this is technology, policy, pathways, way of collaborating, what do you think would make the biggest difference for patients?
Well, lots of things. I mean, if you had a blank check, you could just think about all the lovely technologies that you might want to implement in the different hospitals and see how quickly that could move on and just get more diagnosis. But actually, I think, we've got to take a bit more wider perspective on things. And I think we've got to be really disruptive in the way we do things. I mean, as you know, all these new techniques using deep learning, machine learning, and AI are really progressing at such a fast pace. And at the same time, in parallel, there's lots of clinical trials being done in parallel as well. They're moving at such a fast pace, particularly when you look at the field of oncology as an example, all these new trials rapidly being done. And by the time we are able to make informed decisions about, right, what we need to do, actually that tech or those clinical trials might be out of date because a new study's come about or new technology being deployed. So I think what we need to really be thinking about is, if we really want to move the needle forward, is be a bit more disruptive about how we use our data. And rather than wait for the data to come in and reflect on it and then write a guideline a few years later, if we really want to be really dynamic, I think this might sound slightly crazy, but I think what we need to do is capture that kind of data real time to all our patients. If we're capturing that data real time at point of care, it's integrated, and then we have an iterative system where it is used to improve our pathways and diagnosis. That's actually where we're going to see really big gains, where we're actually capturing that data at point of care and it's being embedded and used for research purposes and also enhancing the clinical pathway. Because that doesn't need a brand new scanner or a brand new device. It just means a sensible approach to just capturing what we already got, which is data for free. But managing that data for free is complex. But then that's where you might have tools, AI tools or digital twins, or other novel approaches where actually you can capture that data and say, right, this is what we think is going on. What can we do better with this data for our next patient that we've seen? And before you know it, in a few months' time, you're already making a difference to patients. Sounds slightly wild, but I think that's the kind of disruptive things we need to think about in the future of our patients.
Yeah, and just a couple of points around that. I think that, as I mentioned earlier, I think the adoption of innovation can be quite slow for various reasons. And I actually have companies that come and speak to me about AXREM membership where they've got an amazing, innovative product. And I'll go back to them a month later and say, do you want to join? And they're like, we decided not to do business in the UK because it's just too difficult to get innovations into the NHS, which we need to do better at that. And I know the Department of Health and Social Care are looking at innovation pathways and other things like that, which is really important. But I agree with the data. We just need to work much smarter and really maximise the use of that data, because that's going to inform so many decisions within the NHS. And I think when we were talking earlier about the images being transported, if you like, from one trust to another, we see a great example of the NHS app working brilliantly for patients. So I can log into my app and all my data's there. I know exactly when I last went to the doctor, when my last prescription was approved, and if we could have a system like that that you guys can use as clinicians, that is much more informative and transferable from one trust to one area of the country to another, that's going to just inform your decision making so much better.
Yeah, no, I agree. And I think there's efforts being done to do that. So we've got a really good electronic healthcare record system that we use at our trust. And I think it's fantastic and it works really well. It automates a lot of these tasks. But there's a big role. There's a huge opportunity for us to do more, I think.
No, I agree. Thank you.
I wanted to ask you, Sohaib, also, again, reflecting while we were talking. I mean, I think it's been amazing to see how much technology and the adoption of technology has improved in the last few years. And the main result of this is that we have also a population that lives longer, which is in itself great, right? And but that also means there is more exposure to disease, and one of the elements is also that sometimes the disease intersects, and in your case, I know you are very much working also on cardio-oncology, which is basically the impact that oncology and that kind of disease has on the cardiovascular system of your patients. Please correct me if anything is inaccurate here. But in a way, this is adding an additional layer of multidisciplinary, an additional layer of complexity. Do you think we are ready to tackle that? Where do you think we are also from the way we collaborate, industry, clinicians, NHS, and so on, and a general reflection from you around this?
Yeah, excellent points you raised, Julia, and I completely agree with all aspects of what you said. And I think we are heading to a bit of a tsunami about what healthcare would look like in a few years' time. So while cancer and cardiovascular disease are the two biggest causes of death worldwide, actually cardio-oncology is where the fields collide and where you have problems at the point of cancer treatment, but also the long-term survivors. Because we know a lot of these cancer survivors have a lot of cardiovascular problems that manifest much later in life. And that's things that we need to address now, because these are becoming more and more of a problem. We don't have systems set up for cancer survivorships or cardiovascular care. And so that's one perhaps tangible thing I think maybe we should think about after the end of this meeting, actually, what we're doing these patients, maybe as a new pathway for our own local trust. But actually, the other point you made, Giulia, was also about complexity of disease processes. So patients don't come in anymore with just, well, I've got a heart attack, or I've come in having one problem, my heart, having a disease. Actually, that disease process of a specific part of the heart might be so intricately related to lots of the disease processes around the body. And that's where the concept of multi-morbidity is going to be a real problem in the next decade. There's a quote from one of the NHS England looking at what the projection of multi-morbidity is going to be like in 10 years' time. And multi-morbidity is where you've got a disease process of 2 or more organs. So cancer and liver disease is an example. So maybe heart and liver, or kidney and brain disease, whichever combination. And actually, it's expected actually more than half the population are going to be having these kind of problems in 10 years' time. The question we've got to ask ourselves, what are we doing about this? What are we going to be doing? And actually, we need to not only have the right healthcare professionals to look after these patients, but also the right technologies to deal with these complexities. And it goes back to what we were saying. If we've got that real-time AI capture of the data, that's where it's going to embed in the future. But we need to think about having tools that are going to address these complexities. Because at the moment, sometimes we only look at disease processes in single organ or single disease processes. But actually, it's going to be far more complex in the future. And I think this is where we all need to work together. Industry needs to come together with academia and also at the front line of the healthcare to understand what are these challenges and what are we going to do to solve them, because it's going to be a real problem from the healthcare system and also from a socio-economical burden for the UK government, how we fund this and having the right kind of treatments involved before all the impact takes it takes a hold on the patient's health and also the healthcare system.
Yeah, and you've mentioned a couple of times during the podcast about preventing disease. So how can people prevent cardiovascular disease? How can we lighten your workload?
Yeah, so it's a great question. Actually, I did part of my job actually is I know we talk about imaging and cardio-oncology and multimodal imaging, but actually I really enjoy doing preventative medicine. There's lots of things we can do from a cardiovascular perspective. There's simple things like asking patients to stop smoking, making sure their diabetes and cholesterol is well controlled. But actually, if we're able to harness that, okay, and personalize it for all our patients using personalized imaging, things like coronary calcification scores and a CT scan, looking at early markers of heart dysfunction on MRI or echo. These are things tools that we have readily available now that we can use for screening of patients. But also it's trying to identify which patients will get those problems in the future. But we've got a lot of risk tools available. And it's about actually using those a bit more widely and getting. One thing we've not talked about, Sally, actually said all these ideas are actually wonderful, and there's companies that have got all these fantastic tools out there. So one of the major things is about the reimbursement. So if there's no reimbursement model, it's very hard to deploy technology in the UK healthcare system, because actually that company or SME that's got a new tool is going to go bust if they just keep on working without any return. So actually the reimbursement of those preventative tools is going to be what I think will be really, really important, because there's lots of out there already, but we just need to apply them and also make sure there's an adequate reimbursement model for the people who come up with these tools, so that actually we can be the world leaders of innovation and technology. And when we plan that money back into R&D to the innovatives, that can then go into make the newer tools that for the next 5 years, the 10 years for these multi-morbidity patients, actually that's where we're going to be excelling and leading the way forward in the world, I think.
Yeah, I totally agree. And obviously, we hear from the government that they want the UK to be the life science powerhouse by 2030. It's now 2026. Like we've only got 3 full years to achieve this. And so I absolutely agree with you on that point. But yes, I think we've all got a role to play, to be more healthy, live more healthy lifestyles. So hopefully then that does reduce your workload a little. But we're going to move on now, and we're going to mix things up a bit and be a bit more lighthearted. So we always end a podcast with our quirky question. And I know at the beginning you were slightly worried about this. So I've actually thought I will answer the quirky question first for you to give you an idea. So our quirky question today is, if you could have a solo dinner with one person, anyone in the world living today, who would it be and why? So I was just thinking about this and basically following our conversation, I'd probably be a bit greedy and want to have dinner with Wes Streeting and James Mackey, because I would really, really like the NHS and the government to see industry as a true partner to the NHS. And it's very frustrating for me. I write a lot of letters to ministers and to Wes Streeting, but actually getting them to speak directly to us is quite a challenge. So in my role, it's probably my biggest frustration. And I think that when the government made the pledge during their election campaign to double scanner capacity, AXREM represent 100% of scanner suppliers in the UK. They've never directly came and spoke to us. And it's really frustrating, because it's like you said, it's not necessarily that we need more equipment, we just need to use the equipment more smartly. And I would imagine that the OEMs, so the manufacturers of the equipment, can show the NHS how to work smarter with their equipment to help capacity. So mine's a very kind of worky one rather than a personal one, but you can have either. So we'll now go over to Dr. Nazir to give us your answer. Who would you like to have a solo dinner with?
So West Streeting was not bad, I think. I think that's a good choice, I think, and reflecting on that. So, but just maybe for the audience who are listeners, we had a pre-meeting. I just had a quick question about the person I wanted to nominate to have dinner with, but he's now in prison. So, but he was so I can maybe I'll just go back to that, because actually it was Imran Khan, who many of you may know was a famous cricketer in the 1990s, but also led a very large successful political party to try and change and democratize parts of Southeast Asia. So I think he still is probably the person I'd go for dinner with at the moment. But I guess if we want to make change like through AXREM, we probably need, not with just one person, we need a round table dinner with lots of people. We need clinicians on the table who are frontline, seeing all the problems at the front line. We need academic researchers who are at the forefront of cutting technology to understand what is possible and that interface between healthcare and industry. And then also industry partners just understanding what is the problem going forward. Because actually, if we have those round table discussions beyond a solo dinner, then actually that's where we're going to make change. We all do it collaboratively together. Because sometimes I've gone to some events and I think I've heard a talk about a tool and I think that was a brilliant tool, but probably doesn't have much role in a couple of years' time, because something else is going on. You know, that problem is going to be phased out, or another company's got this going. You know, this other tool that's been developing. So if we're all actually singing from the same hymn sheet at the same dinner table, then we're not going to be working in silos. And then we'll all do it together collaboratively, cross institution, cross national, cross borders. And that's all going to make impact, I think.
I totally agree. And I'd like to think that AXREM is a great platform to be able to do that in all of our work. We, we collaborate with the societies and royal colleges, the RCR, SOR, BIR, and all the other acronym organisations, because the clinical voice is so important. We have to do this together as one. So I totally agree with you. So thank you very much. Giulia, same question to you. So if you could have a solo dinner with one person, anyone in the world, who would it be and why?
So mine is truly going to be lighthearted, and I'm a big fan of tennis. So I would say either Roger Federer or Serena Williams, and the reason being, apart from a personal passion for the sport, I would say that when someone is for a very long time at the top of their game, you have also a lot to learn from them when it comes to handling pressure, handling constant kind of scrutiny, and being at the top of your performances all the time. And I guess that there is a lot of insights and learnings that you can translate into every profession, and therefore, in that sense, I think I would have a lot to learn from either of them. And then, I mean, just to comment on your thoughts when it comes to changing things in our field, I agree that rather than solo dinner, what we probably need to have is more intentional, I would say, discussions in larger rounds, particularly when it comes to multidisciplinary rounds. And I agree with you, Sally, that's something where AXREM is an excellent platform, and there is the potential to be even more so. That's something that we also try to steer with our Future Leaders Council, and I'm looking forward to have more of that.
Dr. Nazir.
I've got a comment actually. I'm really glad you said Roger Federer or Serena Williams, actually. I'm actually a massive tennis fan as well, and I actually grew up in Wimbledon, so I was always watching tennis when I was growing up. But there was one really inspirational thing that I heard from Roger Federer after he retired, and I'm sure Giulia and Sally you've heard this, but he gave like a coaching talk about how he got coached, and something I've taken away as well, and I think something we should do for healthcare, by the way, as well. Not saying we should be throwing tennis balls around the industry or the hospitals, that probably won't go down right. But one of the things that he did is that he said, I think as a top ranked tennis player, he won about 70 to 80% of matches. Yet if you look at his point score, if you look at every ball he played, actually he only won about 50% of them. So with a 50% success rate per ball or per shot, he managed to win and be one of the most successful tennis players in the world. And the way he did that is that once he took on a task or took on one serve or played one ball, whatever the outcome of it would be, he would get about it and focus on to the next ball and the next point. Because actually and then that way you don't, sorry, I'm slightly digressing on this one, but it was a really good point for me, because actually rather than gloom on when things have not gone well, you just focus on the next point. And equally, once you've done really well, you don't gloat about it. You just go on and keep on trying to be persistent and consistent. And that's where success begins. So yeah, I think I would also like to join you, Giulia, if you ever go and have a solo dinner with Roger Federer or Serena Williams as well.
If that happens, Sohaib, I'll make sure I'll invite you.
I was going to say, and if you insist, I will be happy to join you. And I think that your point there, Dr. Nazir, is actually really how the NHS works, as well. Like, if something goes wrong, you don't stop, you carry on, because you want to do best for your patient. So you continue to, fight barriers and difficulties to make sure you're always doing what's right by the patient. And that's why we're all here, and we're all doing the different jobs in the different sectors and areas. But like you say, together and collaboratively, we can achieve so much. And I think that's a really great point to actually end the podcast on. So it's been great to get to know more about you, Dr. Nazir, and get some further insights into cardiovascular disease. A big thank you to Dr. Nazir for joining us. Thank you to Giulia for being my guest host, and thank you to all of our listeners.
Join AXREM at our external stakeholder conference, Imaging Tomorrow, Innovation, Insight, Impact, on Wednesday the 14th of October at the Royal Society of Medicine. From NHS policy and community diagnostics to AI in practice, sustainability, procurement and cybersecurity, this is where big ideas meet real-world impact. Hear the latest thinking, explore the challenges and connect with leaders from across the NHS and medtech. If you care about the future of diagnostics, this is the room to be in. Secure your place now at www.axrem.org.uk/event/AXREM-external-stakeholder-conference, or click the link in the show notes.